You know, when you decide to renovate an old house, you don't just walk in with a sledgehammer and start blindly knocking down walls.
Right, you'd completely wreck the place.
Exactly. You need the blueprints. You have to know if you're dealing with, like, peeling paint on the surface or cracked drywall or, a massive structural failure right down in the foundation.
Because if you try to fix a crumbling foundation with a fresh coat of paint, you're going to be incredibly disappointed
Yeah, and out a lot of money.
and potentially causing a lot more damage in the process. I mean, you really have to understand the specific anatomy of the house before you pick up a single tool.
Which brings us directly into today's deep dive. We're looking at a topic that a staggering number of people search for in the privacy of an incognito browser tab, but very few feel comfortable talking about openly.
Vaginal rejuvenation.
Vaginal rejuvenation and tightening, yeah. And we've got a massive stack of source material today for you to help kind of cut through the glossy clinic marketing and those heavily edited brochures.
There is so much marketing out there.
Oh, it's everywhere. We're pulling from medical literature, clinical trial protocols, comprehensive clinic FAQs, and the incredibly cautious guidelines from the UK's National Institute for Health and Care Excellence, or NICEs.
The clinical landscape for this is just filled with a lot of noise. You have clinics promising miraculous results for everything from painful sex to urinary incontinence, and they're all using the exact same machines.
Right, which makes no sense mechanically. So our mission for you, the listener, is to sift through that noise and answer one very specific biomechanical question.
Does treatment depth matter when we talk about vaginal tightening?
Okay, let's unpack this, because to even approach that question, we kind of have to define the problem first.
We do. When patients report what the medical literature actually calls vaginal laxity, they're describing a subjective physical sensation of looseness in the vagina.
Subjective being the key word there.
Exactly. They might feel a lack of friction during intimacy, or just this feeling of heaviness. And this can be triggered by a variety of distinct factors.
Like childbirth, obviously.
Right. The physical trauma of childbirth is the most obvious one. It stretches and sometimes physically tears the pelvic tissues. But it also comes from the natural aging process, or the hormonal shifts of menopause.
Specifically, genitourinary syndrome of menopause, right? GSM.
Yes, GSM.
What exactly is happening during GSM? Because, menopause is usually associated with hot flashes and mood changes, but this sounds much more localized.
It is. So during menopause, estrogen levels just plummet. And estrogen is essentially the hormone that keeps vaginal tissues thick, elastic, and well lubricated.
Okay.
So when estrogen drops, that tissue becomes incredibly thin, fragile, and dry. This leads to micro tears, changes in the local microbiome, and just a lot of pain or irritation.
Wow. Okay. So a patient might feel laxity because the tissue itself has lost its structural elasticity, not necessarily because the muscles are torn from having a baby.
Precisely. It's a tissue problem in that case, not a muscle problem.
We know there are surgical options out there, like a vaginoplasty to stitch things up, and conservative treatments like Kegel exercises. But today we're focusing strictly on energy-based devices, lasers and radiofrequency.
Right, the non-surgical route.
Yeah. But before we get into how these machines actually work, we need a better understanding of the tissue they're firing energy into.
Well, the vagina is basically a fibromuscular tube. If we look at a cross-section, you can break it down into three main layers. The first is the internal mucosa, specifically the stratified squamous epithelium.
Okay, in non-medical terms, what does that actually look or feel like?
Think of the tissue on the inside of your cheek.
Oh, okay.
It's a mucosal lining, it's delicate, it's meant to stay moist, and it's the layer that interacts directly with the outside world. That is your surface paint, going back to your house analogy.
Got it, the paint. What's next?
Below that mucosa is the intermediate muscularis layer. This is smooth muscle, meaning it operates automatically. You don't consciously flex it.
Right.
And finally, on the outside of that tube, you have the external adventitia.
Adventitia.
Yeah, this is a dense, fibrous, connective tissue layer that anchors the vagina to the surrounding structures in the pelvis. It is incredibly rich in collagen and elastin.
So it's basically the structural support beams.
Exactly.
So going back to our house analogy, if the vagina is the house, Kegel exercises and physical surgery are fixing a cracked foundation, right? The deep pelvic floor muscles.
Right.
But these energy devices we're talking about today, they're more like patching the drywall and repainting.
That is the crucial distinction that clinics so often gloss over. Vaginal tightening is used as a giant catch-all marketing term.
Yeah, it's everywhere on Instagram.
It really is. But if a woman has genuine pelvic floor muscle weakness or severe structural damage from a difficult childbirth, that requires physical therapy to strengthen the muscle or actual surgery to physically repair a tear.
So energy devices target tissue-level laxity instead.
Right, the thinning of the mucosal walls, the loss of elasticity, and that menopausal dryness we mentioned.
Wait, hold on. If someone had a baby and literally tore a pelvic floor muscle, like the levator Annie, are you saying a laser isn't going to fix that? Because some of these clinic websites definitely imply they can tighten everything back to a pre-baby state.
I cannot stress this enough. A laser or radiofrequency device absolutely cannot fix a torn muscle. It cannot correct severe pelvic organ prolapse.
Wow,
If the foundational studs of the house are broken, applying heat to the drywall is not going to rebuild them.
that makes sense, yeah.
What these energy devices actually do is use controlled thermal injury to trick the body into healing itself.
So we're intentionally injuring the tissue to get a result. That sounds intense.
It sounds counterintuitive, but exactly. By heating the tissue to a very specific temperature threshold, the devices trigger the body's natural wound healing cascade.
Okay,
The heat stimulates fibroblasts. You can think of fibroblasts as the cellular construction workers of your body.
I like that, the construction workers.
Yeah, when they sense this thermal injury, they rush to the site and start churning out materials. This triggers neocollagenesis.
Which is the creation of brand new collagen fibers, right?
Yes, and neoelastogenesis, the creation of new elastin. This whole process thickens and firms up the existing mucosal and fascial layers over time.
Okay, so if the goal is to trigger these construction workers by heating up the tissue, it seems like the first tool most clinics reach for is a laser.
It's definitely the most common.
Looking at the literature, there are two main players here. The CO2 laser, which operates at a 10,600 nanometer wavelength, and the ERYAG laser, operating at 2,940 nanometers.
Right, the big two.
The studies keep calling these microablative or fractional lasers. What does that actually mean in practice?
Well, it comes down to what the laser beam is actually targeting. Those specific wavelengths of light are highly absorbed by water.
Just water.
Yep. And human tissue, especially mucosal tissue, is predominantly made of water. So when the laser fires, it doesn't just, warm the tissue up. It hits the water molecules inside the cells and instantaneously superheats them until they literally boil and turn into vapor.
Wait, we're boiling the water inside human cells until they vaporize. Doesn't that cause massive damage?
Well, this is where the fractional part comes in. The device doesn't vaporize the entire surface. It splits the laser into dozens of microscopic beams.
Oh, gee.
So it vaporizes tiny microscopic columns of tissue, leaving healthy, untouched tissue all around those columns.
Which allows it to heal faster, I assume.
Exactly. It allows the area to heal incredibly fast. But the secondary effect is the heat. While the center of the column is vaporized, the tissue immediately surrounding it is heated to about 45 to 60 degrees Celsius.
And what happens to the tissue at 60 degrees?
When existing collagen fibers hit that temperature, their triple helix structure actually denatures. They physically unwind and shrink.
Like taking a heat gun to plastic shrink wrap.
That is the exact mechanism. You get an immediate visible contraction of the tissue.
But if you're vaporizing tissue and superheating collagen, how is this not agonizing for the patient? I mean, 60 degrees Celsius is hot.
It's because of the depth. Lasers, by their very nature in this specific application, are incredibly superficial.
How superficial are we talking?
The CO2 laser only penetrates about 20 to 125 micrometers deep into the tissue. To put that in perspective, a single human hair is about 70 micrometers thick.
Wow.
And the ERYAG laser is even shallower, penetrating only 1 to 3 micrometers.
So it's literally just skimming the absolute surface paint of the house.
Exactly. Because the penetration is so incredibly shallow, it completely avoids the deep nerve endings.
That explains the pain factor.
Right. It usually only requires a topical numbing cream or sometimes no anesthesia at all. The entire procedure might take 15 to 30 minutes, and the patient can essentially go right back to their normal day.
Okay, but if it's only going a few micrometers deep, like less than a hair, what kind of symptoms is that actually fixing?
What's fascinating here is that because the laser acts instantly on that local, superficial mucosal tissue, it causes a strong, immediate thermal contraction of the vaginal lining.
That pulls it tight.
It creates an instant mucosal folding. This makes it highly effective for treating surface issues. If a patient is dealing with that genitourinary syndrome of menopause, the severe dryness, the thinning tissue, the surface itching, the laser forces the body to rebuild that mucosal lining.
Bringing back the lubrication and thickness.
Yes. And it's also remarkably effective for mild stress urinary incontinence.
Stress urinary incontinence, meaning when someone sneezes or jumps on a trampoline and they leak a little bit of urine.
Yes. When the laser immediately tightens that front mucosal wall, it can physically alter the angle of the urethra just enough to provide better support.
Oh, wow.
It acts almost like putting a slight kink in a garden hose, preventing that mild leakage.
Okay, I'm tracking with the lasers for the surface paint. But what if the problem isn't just menopausal dryness? What if the patient has real structural laxity deeper down in that fibrous adventitia layer we talked about earlier?
Right, the drywall and the structural supports.
Yeah, because the lasers clearly aren't reaching it if they're stopping at a hair's breadth. This is where the literature introduces radiofrequency, or RF therapy.
And RF changes the depth equation entirely because it relies on a completely different physical mechanism.
RF systems, like the Vivave or Therniva devices, they don't use light beams to vaporize water. They use high-frequency electromagnetic waves.
Right.
But how does an electromagnetic wave generate heat without burning the surface?
Think about how a microwave works. It doesn't use a hot element, right? It uses electromagnetic waves to create friction and resistance inside the food.
Yeah, it heats from the inside out.
Exactly. RF devices pass an electrical current through the tissue. The tissue naturally resists this current, and that resistance generates heat deep within the structures.
But the energy still has to pass through the surface mucosa to get down there. Why doesn't the surface burn?
The major clinical innovation with RF devices is reverse gradient or surface cooling.
Surface cooling.
Yeah. The wand delivering the energy actually cools the delicate surface of the tissue, sometimes using a cryogen spray or just a chilled tip to protect it.
That's clever.
It keeps the paint perfectly safe while simultaneously driving the electromagnetic heat deep inside to the drywall.
Which brings us back to our central mission for you, the listener. Depth. We know lasers are operating in micrometers. How deep is RF actually going?
Radio frequency penetrates in millimeters. It pushes heat up to 3 or 4 millimeters deep.
That is a massive difference from 3 micrometers.
Huge. It completely bypasses that surface mucosa we talked about, reaches down through the submucosa into the deep lamina propria, and can even heat the superficial muscle layers and the pelvic fascia.
Okay, so if lasers are like giving a steak a hard, fast sear on a hot grill, affecting just the outside crust instantly, RF is like cooking it sous vide.
I love that analogy.
You're gently and slowly raising the temperature deep inside the meat without burning the outside at all.
Precisely. With RF, the goal is to hold that deeper tissue at a sustained temperature of around 40 to 45 degrees Celsius.
So a bit cooler than the laser's 60 degrees, but much deeper.
Right. And because it's a slower, deeper heat, you don't get that instant shrink wrap effect like you do with a laser.
So no immediate tightening.
Not immediately. Instead, it stimulates those cellular construction workers, the fibroblasts, to secrete collagen and elastin over a much longer period. The clinical trials show a very different trajectory for the results.
Let's look at those trials, actually. There was a randomized sham-controlled trial, the VIVEE trial, that looked specifically at RF for vaginal laxity.
And a sham-controlled trial is really the gold standard for this kind of research. They essentially gave a placebo treatment to a control group.
A placebo laser, or, well, RF wand.
Right. They inserted the device, but operated it at a clinically ineffective energy level. The patients had no idea if they were getting the real thermal treatment or the fake one.
And what happened?
At the 6-month mark, 43.5% of the women in the active RF group reported having no vaginal laxity at all.
Wait, none?
None. It completely resolved their primary symptom.
That's massive. Over 40% resolution at 6 months. But what about the sham group, the placebo group?
In the group that received the fake treatment, 19.6% reported improvements.
Wait, hold on. Almost 1 in 5 women felt their vaginal laxity improve from a machine that was essentially turned off.
Yep. 19.6%.
That is wild.
It is, and we will definitely come back to why that number is so incredibly important in just a moment. But to directly answer the core mission of our deep dive today, does treatment depth matter?
Well, based on the mechanisms we just walked through, it dictates everything.
It does. Depth dictates both the speed of the clinical outcome and the longevity of the results. The comparative studies in the literature outline this perfectly.
So how should someone choose?
Well, because the laser hits the surface and causes instantaneous thermal stripping, it is superior for rapid symptom control. If you have severe surface atrophy from menopause or mild stress urinary incontinence, you want the laser.
Because it tightens the mucosa immediately.
Exactly. But if a patient feels like the physical structure itself is loose, they need to go deeper.
which means RF.
Right. RF acts on the fascial ligaments. It takes nearly half an hour of warm thermal energy to penetrate down there. But because it is remodeling the deeper structural fascia and ligaments over a period of months, it offers much greater durability and longer-lasting results for moderate cases of laxity.
Okay, so depth matters because it determines whether you're treating the surface lining or the structural fascia.
You nailed it.
The science of thermal depth and cellular remodeling makes total logical sense. But if we do a medical reality check and look at the regulatory landscape, things get complicated really fast.
Very complicated.
Because despite these clinical trial numbers, and despite tissue biopsies literally showing brand new collagen under a microscope, these devices are not FDA approved specifically for urinary incontinence or sexual function.
No, they are not. They are cleared for general gynecology, but not for these specific marketing claims.
And the UK's NICE guidelines are hitting the brakes hard on this too.
It is crucial to understand why regulatory bodies are so cautious here because it directly impacts patient safety.
But if the biopsies show new collagen being built, and 43.5% of patients in a trial are actively checking boxes, saying they feel tighter and have better sexual function, what is NICE seeing that we aren't? Why aren't they recommending this as a standard first-line treatment?
It really comes down to how we define long-term clinical evidence. NICE does not endorse the routine use of these energy devices for vaginal laxity because the long-term evidence is still considered inadequate and highly heterogeneous.
Heterogeneous meaning, like, the studies are all basically comparing apples to oranges.
Precisely. One study might measure success by patient questionnaires, another might use a device to measure muscle squeeze strength, and another might just look at tissue samples.
So you can't really combine the data.
Right. It is very hard to build a unified medical consensus when every clinic is measuring success differently. Furthermore, we simply do not have decades of data on what happens to this thermally altered tissue 20 or 30 years down the line.
Oh, like, does the repeated heating eventually cause rigid scar tissue?
Exactly. We just don't fully know yet.
And what about that placebo effect from the VIEVE trial? Because 1 in 5 women getting better from a machine that was turned off seems like a huge red flag for the data.
It really highlights the incredible power of the mind-body connection in sexual health and physical sensation. The placebo effect in this specific medical space is massive.
How does that actually work physically?
Well, the simple act of seeking treatment, the anticipation of a cure, and the resulting reduction in anxiety can cause a patient to subconsciously relax their pelvic floor. And that relaxation drastically improves their symptoms.
Which means the clinics might be taking credit for a result that the patient's own brain actually generated.
Yes. This is why the medical consensus, and what NICE strongly advocates, is that women must undergo a thorough physical clinical assessment before ever sitting in a laser chair.
They need a real diagnosis first.
They need to try conservative care, specifically targeted pelvic floor physiotherapy first. You have to rule out other complex anatomical issues.
Like what? What else could cause a feeling of laxity or discomfort if it isn't just tissue aging?
A thorough assessment ensures the feeling of looseness or pain isn't actually being caused by a nerve entrapment or deep dyspareunia, which is deep pain during intercourse.
Okay.
And a very common issue is a hypertonic pelvic floor.
Hypertonic meaning the muscles are actually too tight, like they're locked in a spasm.
Yes. Trauma, stress, or chronic pain can cause the pelvic floor muscles to lock into a constant state of spasm. This spasm alters local sensation in a way that a patient might misinterpret as a structural problem or laxity.
Wait, so what happens if a patient with a spasming hypertonic pelvic floor walks into a med spa, points at a brochure for vaginal tightening, and gets hit with a laser?
It's bad. You apply thermal injury and inflammation to a muscle group that is already in severe distress. You can severely worsen their pain, potentially causing long-term nerve irritation.
Yikes.
The glossy marketing promises a quick, energy-based fix for everything, but the medical reality is that you must diagnose the specific anatomical root cause before you apply any heat.
Which is exactly why understanding the mechanism, what layer of tissue you're actually treating, is the ultimate tool for the patient.
It is. We started with a mission to find out if treatment depth matters. And looking at the wavelengths of the lasers, the radiofrequency cooling systems, and the cellular response of the fibroblasts, the answer is an undeniable yes.
Treatment depth absolutely dictates the clinical outcome.
It does.
So just to summarize for everyone listening, if a patient uses a CO2 or ERYAG laser, they are applying a superficial, fast-acting sear to the tissue. It vaporizes microscopic columns of the surface mucosa.
Right.
It is highly effective for rapid relief of menopausal dryness, surface atrophy, and mild urinary leaks because it instantly contracts that top layer of paint.
But if they need deeper structural support, they need radiofrequency. The RF devices bypass the surface to deliver a slower, deeper heat up to 4 millimeters down into the drywall.
Rebuilding the structural fascia.
Yes, rebuilding the structural fascia and collagen underneath over several months, offering much longer-lasting durability for moderate laxity.
So for you, the listener, understanding this science is your blueprint. It empowers you to cut right through the glossy marketing noise.
Absolutely.
When you sit down with a specialist, you don't just have to ask, will this tighten things? You can look them in the eye and ask, based on my specific physical symptoms, which tissue layer are we targeting? Are we treating my mucosa, my fascia, or are my pelvic floor muscles just in spasm?
It takes the power out of the brochure and puts it back in your hands.
Before we wrap up, it's worth looking at where this technology is heading. Because right now, the current protocols kind of force doctors to make a choice, right? Do we use the shallow laser or do we use the deep RF?
But the future might not require a choice at all.
Right. As we see incredible advancements in 3D transvaginal ultrasound mapping, the technology is moving toward true precision medicine. Right now, it's a bit of a guessing game based on symptoms.
It is.
But what if, in the very near future, you could go in, have a high-resolution 3D ultrasound map your unique individual pelvic floor topography and feed that data directly into the energy device?
That would be incredible.
What if the machine could automatically adjust its frequency in real time, delivering thermal healing to the exact millimeter depths that your specific body needs, seamlessly switching between the surface paint, the drywall, and the deeper fascial supports?
I mean, that level of precision would completely change the landscape of women's health. You wouldn't just be chasing a symptom anymore.
No, you wouldn't.
You'd be following a custom blueprint for cellular repair, targeting the exact depth of the dysfunction.
A perfect renovation. Well, thank you for joining us on this deep dive. Keep asking the hard questions about how things actually work, and we will catch you on the next one.